Welcome. Thank you for joining. My name is Simon Weisz. I'm the co-founder and president at Greenspace Health. Excited to be hosting another educational session that's being put on by our team. As many of you know, our team at Greenspace Health is a leading provider of measurement-based care technology, supporting clinics, hospitals, payers, and health systems to implement measurement-based care in order to substantially improve service quality, better understand outcomes, and report externally to meet accreditation requirements and value-based care goals, which I think we'll talk a little bit about today. Years ago, we noticed that there's a pretty significant need for, say, education around the definition, value, and implementation approaches for MBC. So we began bringing experts in the sector into the conversation to join us in educating the industry on measurement-based care. And, we've previously hosted sessions with some of the, some major leaders in this space that include the Yale University Measurement-Based Care Collaborative, Dr. Brent Mallinckrodt, author of the Brief Working Alliance Inventory, and Dr. David Clark, who is joining us again today. These sessions have been very well received with about typically around like 500 clinical leaders and clinicians registering and joining each event, which I really think speaks to the growing momentum and interest for measurement-based care across behavioral health and substance use, which is really important and very exciting for, for our team to see. So for today's session, I am beyond honored and excited to be joined by our panelists, each of whom are measurement-based care experts and leaders in this sector that are driving major adoption across the US and internationally. And so excited to be joined by Melinda Lehman, Executive Director of Behavioral Health Care and Human Services at Joint Commission, as well as world-renowned applied psychologist and leading global expert on measurement-based care, all the way from the UK, Dr. David Clark, and CareSource's Senior Director of Complex Health Solutions, Behavioral Health, Dr. Sandra Berg. But before we dive into things, just a few housekeeping items to keep in mind. Number one, we're going to have a Q&A style discussion here with each of our panelists, and we'll have dedicated time at the end for questions. Now, please include your questions and type them into the Q&A tab within your kind of Zoom bar at the bottom of your screen, not into the chat. And we're going to use that Q&A to be able to sort and prioritize what questions we'll be able to get to. So there's an upvoting feature. Vote for the questions you want to hear this group answer, and we'll prioritize that way. Item number two, at the end of the webinar, please fill out the survey. It really helps inform our team's educational work that we're doing and where we're spending time. And then kind of last housekeeping item, there's a new Zoom feature called Resources. You'll also see that as a tab in your Zoom panel. We've populated some resources that I think could be relevant and support the discussion today. So if you'd like to learn more, you can explore those. And I think in the chat, somebody's going to link there at some point. So now to get into our topic today of measurement-based care and value-based care. Say a crucial element really in driving sustained improvement in quality of behavioral health services across a system lies in our ability to integrate measurement-based care into care at both an organization and system level. And this concept is also closely connected to value-based care, or whatever, I'll say, like term we're going to put around that depending on, I'd say, sector and location. And really by leveraging robust and clinically meaningful measurement practices, leaders in the sector can effectively demonstrate the value that they can bring to patients and stakeholders. And if we look at value-based care as the need to provide and share the value, aka impact of our work, that our services are providing, and the need to evaluate care by not how many people we see, but the impact we make or value we provide, we can start to transcend the definition of value-based care and can really learn from any model that is valuing outcomes over output. Like Dr. Clark's work with NHS Talking Therapies across the UK. Even though that same term of value-based care might not be as prevalent, the same concept applies, right? How do we move to outcomes as opposed to output? So no matter what the requirements of any value-based care model is, The key is really to easily understand and share the impact of your services and your work, which in many cases will require measurement-based care as a central component. So from our perspective, like embracing measurement-based care not only showcases value through clear clinical outcomes, but organizations and systems are now able to leverage that data to be more proactive in accessing value-based care and ultimately future-proofing themselves for the shifts that we're seeing in this sector. And that's really where we want to take the conversation today. And I think thanks to the audience, it's based on the input and feedback we've been hearing and a lot of the educational work that our team has been doing. So to start off, we know that the Joint Commission hosted a webinar and released a report in 2023 endorsing measurement-based care as a foundational component of evidence-based behavioral healthcare. Melinda, can you tell us a little bit about the Joint Commission and really the impetus for including a standard that's specific to measurement-based care within the work that you do?
So thank you very much for inviting me today. And yes, I work for the Joint Commission, the nation's oldest and largest accrediting body across healthcare. And I work specifically for the Behavioral Health and Human Services Program, which accredits more than 4,200 behavioral health and human services provider organizations across the U.S. We have had an outcomes measurement requirement in place for a long time, but in 2018, we revised it, as you can see on the attached slide. It now requires that organizations have selected and administered a standardized instrument that's appropriate for measurement-based care, and that they use the data to monitor progress and inform care, and they also aggregate the data to assess organizational performance, and that this cycle continues throughout the care process. The goal, of course, is the delivery of high-quality, effective care that improves outcomes. And we have organizations now that do this. Well, I don't know if it's pencil or paper, it's probably more a calculator or spreadsheets, on up to organizations using really sophisticated systems like electronic administration and scoring, along with real-time graphing and feedback through a measurement system or a data center. And on the next slide, really, we did this because we felt the evidence was clear that measurement-based care is an evidence-based practice and should be part of any organization's framework for continuous improvement, a part of their plan to deliver safe, high-quality care. The Kennedy Forum paper shown here, really a national call for measurement-based care in behavioral health and primary care, and I think that came out in 2015. Really covered the evidence well. It discussed how the use of measurement-based care can significantly improve outcomes, and how it can help empower providers to fine-tune treatment plans when patients aren't improving and demonstrate improvement when they are. But it also helps patients participate in rating their symptoms, so that it helps them become a little bit more knowledgeable about their disorders, attuned to their symptoms, and really realize the warning signs of relapse or reoccurrence, which can help really enable them to better self-manage their issues and seek treatment. So it really concludes that it's time to make measurement-based care a standard in behavioral health. We agreed.
That's great. Thank you, Melinda. And I'd say two quick comments from me. One, I have really appreciated seeing the impact that the Joint Commission shift has had on conversations we're having in the sector, and a lot of organizations that are just learning about it and starting the conversation based on the work they're doing with the Joint Commission. And so that really is having an impact. And maybe the other comment to segue here a little bit, like, it's interesting, like since 2015 and that Kennedy Forum paper, like the evidence base has continued to grow. And I think the evidence that is coming out around the impact and value of measurement-based care, to me, it's most exciting to see the data coming out of live, practical, system-level implementations. And I think this is the segue to Dr. Clark's work, right? So Dr. Clark, it's very nice of you to join us again for another discussion here, and really for us to be able to learn from the expertise that you have and the work that you've done in the UK. And so I know we ran a few webinars with you last year. However, we have many new people joining us today that wouldn't have been part of those sessions. For those that are interested, there are recordings and articles and content that are coming out of those conversations that we have on our website. But I think in sort of bringing everybody up to speed here, would love if you could provide the high level overview of like NHS Talking Therapies program and the impact that measurement-based care has made across your services.
Great. Well, it's lovely to join you all today. So the NHS Talking Therapies program is really an attempt to greatly increase public access to psychological therapies because of multiple surveys, some of which have been done in North America, showing that the public has a preference 3-to-1 in favor of psychological therapies versus medication. But in most countries, the public was not getting what it wanted. So the Talking Therapies program is a public promise to do 3 things. 1, to give people an evidence-based psychological therapy if they're suffering from anxiety or depression. 2, to deliver it by someone who's properly trained to deliver that therapy. And 3, really crucial for today's discussion, to try to collect the outcome data on every single person who has a course of therapy and to publicly report the outcome of all of the services. Britt, could you give us my slide? So this is looking at how the program's evolved over time. So it started quite small in 2008. We saw 93,000 people. We currently see for an assessment at least 1 million people. Not everyone has anxiety or depression, but for those who do, they have a course of treatment. The average wait is modest, just 20 days. But the key thing for today is that we use a simple measure of anxiety or depression that patients fill in each week on their mobile phone. They just get a link to it. And by always sort of collecting data each week, even if someone drops out of therapy early, we get a sort of clinical endpoint. So we have clinical endpoints on 99% of that 670,000 people that we treat each year. And you can see how the outcomes have changed over time. So one of the metrics that we use is called recovery. That is someone no longer being in the clinical range of anxiety or depression at the end of treatment. And we had the aim of getting 50% of people to that because the research studies suggest you might be able to do that if you deliver treatment really well. As you can see, when we started the program, we were quite a long way short of that, about 37%. And if we had not been collecting outcome data on everyone, we would still be at that point, and we'd be blissfully ignorant as clinicians. But sadly, round about 100,000 patients in England each year that we could have got to fully recover would not be recovering. But thankfully, because we collected the data, we could see we weren't doing as well as we'd like nationally, but we also found that some services were really doing already very well and some not. And so we could study what the differences are between the different services, and we could study other sources of variability in the data and feed that back into the system. So as you can see, over a number of years, our outcomes steadily improved until we got to our target level for recovery. Of course, not everyone who recovers, some people who don't recover still benefit a lot. And so the dotted line is the people who show marked improvement, even if it doesn't get fully to recovery. And you can see that's about 7 out of every 10 patients. So from our perspective, collecting the data and using it to refine the delivery of your services has a massive impact. And I would want to emphasize that the therapies that we are offering back in 2009 are the same as the ones we're offering now. But the way we organize the whole system has changed, and that has had an enormous impact on the patient outcomes.
Great, thank you, Dr. Plack. And I love that graph and think it does an amazing job of telling the story that, you know, the journey for organizations doesn't stop at implementation. It's such an opportunity to drive quality moving forward and set an organization up for more success. So Dr. Berg, Sandra. Thank you for joining us. I've been fortunate to work with you and your team at CareSource for the past several months as you think and look to implement measurement-based care across providers serving your members. But would love if you could start by telling the audience a little bit about CareSource and why your team has prioritized measurement-based care and see it as essential in the shift towards value-based care.
Well, thank you, Simon, and thank you for inviting me to join today. CareSource is a not-for-profit managed care organization that primarily focuses on Medicaid. So our biggest population is covered by the state Medicaid plans. We are in Ohio, see if I can remember all these states, Ohio, Michigan, Georgia, Arkansas. And we were started with a foundation of really looking at the whole person instead of just the symptoms or the condition that they find themselves in physically or behaviorally. And so we want to find ways to look at how do we move the needle on some of the social determinants of health? How do we look at the person in combination of their physical and emotional health as well? So measurement-based care actually was a passion of mine way back in my early days when I was a therapist, and I was fortunate to be a part of a community mental health center that was very forward-thinking in measuring each session to see where the alliance with the therapist and the client landed. And that was my first introduction to measurement-based care. We didn't know what it was back then. It was just, let's measure and see how things are going. And then we developed a tool that looked at the capability that the person was aware of based on Bandora's work, and used that in our clinical sessions to also measure their ability to adapt and function. And then later on, when I was working for another community mental health center, the DLA 20 that was put out by MTM was introduced as looking at the functioning and how can we really target those areas of functioning to improve a person's care. So all that being said, when I met Simon, it was about almost 2 years ago, he did a breakout session at an association conference that I was at. I was just, it was like the light bulb went on. He's talking about what I've been thinking is missing in our industry for so long. You know, in the medical field, you have some pretty concrete measurements of progress towards clinical goals. So I think of, you know, A1C and trying to get your A1C under control. Those are very, very specific measurements, and behavioral health has really struggled in that area, I believe. And I think now that we've become a little more sophisticated, we can start showing the worth of the work that we do and the quality of the work that we do. So at CareSource, one of our focus is on evidence-based practices like Melinda alluded to, and Dr. Clark. We want to show that the work that is being done by our providers in our network is really of high quality. So we really have a focus on evidence-based practice, and we also have a focus on partnering with our providers. So we even established a community of innovation where we bring our providers together and we talk about what are the challenges that you have, what are the things that are important to you, and how can we set up meaningful ways to get you on the trajectory to a value-based contract. Some of our providers are, like Melinda alluded to, are very sophisticated and have all kinds of infrastructure built in place, and some do not. And so it's meeting them each where they're at to move them along. And I think measurement-based care is that glide path to get them there.
And Sandra, maybe as one follow-up, I know you and I have had this conversation a lot, but maybe in just sharing, we're talking about measurement-based care as part of the path to value-based care, but when we're defining and thinking about value-based care as the, you know, incentivizing activities or outcomes, why do you think that measurement-based care is so central to the shift to VBC in the sector?
I think it prepares organization to be thinking about measuring what you're doing. It hasn't always been the case. And if we're in that mindset of we need to be collecting the data, we need to be sharing that with our clients when they come in to see us, and putting them on that trajectory of always having that mindset of, are we making progress? How do we define and how do we really show the outcomes? When Melinda was talking, I remember I ran some psychiatric residential treatment facilities and had to be accredited by Joint Commission. And the emphasis on outcomes and really having structured definitions of what outcomes are is, I think, the start. When we look at HEDIS measures from NCQA, those are all about outcomes. What are you getting when you reduce that A1C, or what are you getting when the person follows up after medication or hospitalization? So I think the measurement-based care is really setting the stage for the providers to be ready to move into more stringent or maybe more active value-based arrangements.
Yeah, and I think the reality is in many levels of care, like if we think about outpatient mental health or behavioral health, I'll say claims data that's available, HEDIS measures are not going to actually tell the story about quality. And we need that measurement-based care data to be able to understand the impact we're having for folks.
Right, and it also gives the provider a platform in which to go to a payer and say, I've been collecting data, this is what I'm showing, and to negotiate for that value-based arrangement. I mean, anything's possible in my world.
Yeah, I think absolutely that the opportunity to be proactive is there. Melinda, maybe shifting the conversation back to you a little bit. Like last year, the Joint Commission put out this report about how behavioral health providers can make the most out of their data to improve client outcomes. And in the report, it's mentioned that organizations have found it challenging to implement MBC up to the standards that have been set, particularly when it comes to actually using the data effectively. Wonder if you can comment on some of the recommendations that Joint Commission has put forward to overcome this challenge, and any examples you might have of how you've seen MBC positively impact JC accredited organizations.
You're correct. The first 4 years of after we had put the new standard into place, the measurement-based care elements of performance, which is how we score standards, were top frequently cited standards during surveys. The bar chart sort of illustrates that pattern. The gray area represents the portion of surveyed organizations that were in compliance with the standard, which was more than 50%. But in contrast, the colored segments of the bars showed organizations that were cited and on which standard. And as you can see, the number of organizations struggling with finding and consistently using a standardized tool was significant, and it went down every year that the standard had been in place. We are on a 3-year accreditation cycle, so we see about a third of our organizations every year. So by the 4th year, we were looking at organizations who had already been surveyed. And if you want to look at the next slide, in 2018, almost all the survey findings were scored. This is a direct comparison of organizations 3 years apart. But in 2018, they were scored on selecting an instrument, and when we drilled a little down further, they were really not selecting an instrument yet. They were clearly looking for guidance in selecting an instrument. So one of the things we did was develop a listing for organizations of standardized tools that they can choose from. It's not an exhaustive list, but it's a list on our website. And, I'm sure many of you know there are a whole lot of instruments out there. I think we had over 90 something on the list. But we did make that list available just to help organizations in their search for a tool that will work for them for measurement-based care. And in contrast, you can see here by 2021, we were seeing people add the tool. We were seeing a little bit still cited, but that seemed to be because there was a lack of the selected instrument being consistently used with all individuals served, as opposed to not having an instrument altogether. And then obviously there are some still ongoing issues with analysis and then using that data for improvement. So next slide. So you also asked me to talk about examples we've seen of measurement-based care positively impacting our accredited organizations. And, we've seen that having an individual who's a champion for the process in the organization can really positively help drive the entire process. So having a champion is kind of a key. Obviously, getting clinician buy-in early in the process is a key to that, consistent use and smooth implementation. And it's also about choosing the right tool for your organization. Those that did well chose a system that was flexible enough for their unique programs and services, that wasn't a burden to use consistently for either the clinicians or the individuals served, and that delivered results that could be customized for all the users, for the clinician, for leadership, for the individual being served, for demonstration, other areas was key. And then finally, those on the leading edge were leveraging their outcome data in several ways, with their payers for reimbursement, for their clinicians and the individuals they serve and their families to both encourage and demonstrate improvement, and then with the payers with others in how to understand the importance individuals served of continuing treatment and how to recognize a relapse early, all those things that the Kennedy paper touched on. It's really been a win-win-win. We see that they say that using measurement-based care has been positive, generally a positive impact, and it's been helpful in helping them improve outcomes and with staff morale and, with client engagement. So that helps.
It's great. I mean, really appreciate the walkthrough there. And I know that touches on probably a little bit, one of the most upvoted questions here is like already a request on, what are some ways to get buy-in and engage clinicians? And I think like there's a few points in there, like on that slide that were really important. One that always stands out to me is like, what are the flexibility of the workflows? How can this fit the existing organization's workflows as opposed to having to mold to some prescriptive solution or add some heavy administrative burden?
Yes.
That really stands out in making this seamless for clinicians. Dr. Clark, I'm coming back to you. Based on your experience implementing measurement-based care across a national health system level, and like from my perspective, this is really one of, if not the most impressive model of measurement-based care that we see internationally. Would love it if you could share 2 to 3 insights that you feel were vital to NHS's success with MBC. And, thinking about the clinical and system leaders here, what would be sort of your largest recommendations for them to keep in mind when considering implementation?
Well, I'd like to pick up first on Melinda's very useful points about how to get people to collect outcome data and to use it, and just amplify on that a bit, because I think people find it quite surprising that we can get outcome data on 99% of everyone who has a course of treatment. And there are several key bits to that. The first is getting patients to fill in short, simple measures every time they're seen. So if someone drops out of therapy early, you still get a clinical endpoint, and make that easy. So we do that with mobile phones. You get a reminder of your appointment and you click on a link, and then you can fill in the questionnaires on your phone. So it doesn't waste any therapy time. You then have to train the clinicians to use the measures to guide what they do in treatment, so they don't see it just as a bureaucratic exercise. And that really seems to be very important. And to link it into an IT system where patients and therapists can see graphs of progress, which is very rewarding. But we also found that the way you choose to report the results is very important. So we chose early on to publish for every service what we call demonstrated recovery. So say you treat 1,000 people and you only get outcome data on 500, and 250 recover, we don't say your recovery rate is 50%, we say it's 25%. In other words, we assume that if you didn't collect the data, the person didn't improve. This is a harsh assumption, but it turned out to be a wonderful behavior change strategy because it removed from all of our clinicians any incentive not to collect the data, because if you don't collect it, you don't get assumed to have got any benefit. And so within 10 months, we moved our system from data completeness of less than 10% to well over 90% across the whole of the nation. So I think that was really a quite important decision to make. Of course, when you get the data on everyone, you can discover some wonderful things. So we found, for example, as we started to treat people with depression and diabetes, that when we put them in our standard depression treatments and group treatments and things, they got better from their depression, but their diabetic control didn't improve. But when we then piloted some more specialized groups, which also had a focus specifically on diabetes, we showed dramatic improvements in diabetic control as well. And similarly, we've been able to look at finding those groups that don't benefit so well and working out how to change things. So back in 2015, we found that there was a significant, fairly substantial difference in outcome rates between the white population and the black population, which is not acceptable. But that was true nationally. However, when we looked at the individual services, we found some were doing equally well with those two groups, even though they were in very deprived inner city zones. And so we learned from them what they were doing, and we fed that back into the system. And now we have no difference in outcome between the white and black population in the UK, and both of them are doing a lot better. So really, it's sort of like stardust, which allows you to do things you can't do without the data.
I appreciate that. And I think the tangible examples are really helpful, especially as you go through implementation, to be able to, make it easier for clinicians and care teams to understand the potential value for clients, right? Like, as opposed to thinking about, external use of data, it's about internal use of data to drive better quality. And
I think we'd say it's very motivating for clinicians. I mean, most of our clinicians got into doing what they do because they really want to help. And when they learn that the data allows them to do more impressive things than they were doing before, it allows them to move things up in terms of the effectiveness of their service. It makes it a lot easier for them to get up in the morning and turn up in the clinic.
yeah, for sure. Sandra, I'm hoping you can share with us a little bit about how CareSource is thinking about approaching measurement-based care and value-based care, and how, we've talked a lot about this, but how collaboration direct with providers kind of plays into that model.
Yeah. So we have had challenges finding really strong ways to incentivize our behavioral health providers. Typically, it focuses on the inpatient hospitalization, the 7-day follow-up, the traditional HEDIS measures. And so wanting to look at things from a new lens and seeing what is it that the providers want to engage in, and like Dr. Clark talked about, is motivating the organizations to really look at their outcomes and how they can come to us and say, look, we're seeing significant results in this population, and we're measuring it, and we're showing you that we're making a difference, has really given us some insight into how we can really structure our value-based contracts. Sometimes a provider isn't ready for a full risk contract, so maybe they need incremental ways to get there. So using measurement-based care within CareSource's strategery, it's a word I use with my kids. Our strategy is to, okay, let's see where they're at. Let's find out where they are in the process. And in our conversations with Greenspace, that's what I appreciate about your approach is let's see where they're at and move them along that continuum to get them ready for value-based contracting. We know that behavioral health is a little bit behind. Actually, it's a whole lot behind when it comes to value-based contracting because the focus has been primarily on large physical health provider groups. And, it's time, I always think of this in the parity sense to bring us equal up to what the physical health experiences around value-based contracting.
Yeah, that's great. I think a theme that hopefully is helpful for a lot of the folks in the audience today that I didn't appreciate maybe 12 or 14 months ago, but do now is the willingness of, like, I mean, in this case, CareSource, but probably the willingness of payers generally to have the conversation. And there isn't a set model today that's, a clear cookie cutter approach to measurement-based care and value-based care. And there's an opportunity for the provider to invest in the practice and go direct to the payer and whether it's negotiating rates or negotiating a value-based care arrangement, but a provider is in a way better position to do that when they have the data and they've built a model that works for their organization, as opposed to for somebody else.
Absolutely, yeah.
Maybe like in the last question before we get to the Q&A here, continuing the value-based care thread, but in a different country. So, Dr. Clark, we know the UK healthcare system is different than in the US. And I think it's probably pretty easy for everybody in the audience to say, yeah, but it's the UK, it's not the US, and the system looks different. And that's absolutely true. But I'm curious if you can kind of talk us through your experience, because at one point you had to get buy-in for the Talking Therapies program to be funded at a system level. And I'm curious if you could share a bit about the economic arguments that you felt really resonated with key decision makers and are true about measurement-based care, regardless of the scale of implementation or whether you're in a single or multi-payer system.
Well, I guess our basic argument comes from a stump speech of one of the US past presidents. It's the economy, stupid. What we really argued in England is that if you deliver effective psychological treatments at scale, then you save an enormous amount of money in your healthcare system because people have many less physical investigations, and we argued that itself can cover most of the cost. But also, of course, people participate in the labor market much more. They're more likely to be back in work, and when they are in work, they're more productive. Their mind isn't elsewhere. And those two things together, we argued, would more than cover the cost of the program. And I think the savings in other healthcare costs are, of course, something which applies however you organize your healthcare system, whether it's through an insurance system or it's through a government system, because obviously the providers are providing across the range of health. That was the argument, but we now, of course, because we've been collecting data on everyone, have evidence for that argument. And the evidence is really pretty overwhelming, not only in the UK, but in many other countries which have now adopted a similar type of talking therapies program. So just to give you a few illustrations, here in the UK, by using data linkage to general hospital records and things like that, we've been able to show that if you're treated in the talking therapies service, you have much lower, less frequent and much lower costs for general admissions, outpatients and inpatients in physical medicine, and that they cover a lot of the cost of the delivery. And you also move into more likely to move into employment. But one of the nicest studies actually comes from Norway, which have followed the same model and have done a wonderful randomized controlled trial where people were either treated in primary care with the best treatment that was available there, including access to psychologists and psychiatrists, or in the new version of the Talking Therapies program. And what they found is that the recovery rates were about twice as good in the Talking Therapies program. But what is really good is they followed people up for the next 3 years using data linkage. And they showed two things. Firstly, that the people who were treated in the Talking Therapy service cost less in terms of their general physical health care. The second is that they, rather miraculously, given the Norwegian data system, were able to track the income of everyone. And they found that those people who were treated in the Talking Therapy service over the next 3 years had a higher personal income than those people who were treated in primary care. This difference in your income, you can divide that by the extra cost of the service, and this gives you a calculation of the benefit to cost ratio for the economy as a whole. It is 4, which is pretty spectacular. So, if you invest $1 billion, you get $4 billion back for your economy. That's Norwegian data. Spanish data shows exactly the same. So does English. And recently, this encouraged the head of our finance ministry, our chancellor, to release a lot more about, I guess, about $800 million additional investment in Talking Therapies, simply because he's convinced it helps grow the UK economy. So its economy is stupid.
Yeah, that is great. That is great. And I think in the US within the healthcare system, there's a lack we have a gap in the chain, right? In terms of having detailed enough measurement-based care data and matching that up, as has been done in Europe, to other data, whether that is cost of healthcare, and that's going to be the more direct impact for a US payer, or whether that's sort of broader economic impact in terms of salary and productivity of a workforce. And I think it's an amazing opportunity for us to be able to learn from places where this has been done extremely well, and these links in the chain have already been made. So I'm going to transition now into the audience Q&A. So I'm going to pull this up on my screen, and as I mentioned, I'm going to go based on upvotes, and make this a bit of a free for all across the group here. And I'll start with the first question on the list. Can you share some tips for getting buy-in from clinicians and staff who are already burdened by heavy documentation requirements? And maybe as we go around, like if there's sort of 1 or 2 or 3 like really key learnings that you've had within the work that each of you have done, that would be a great place to kind of do the circle around. So maybe just to keep this easy, like Melinda, I'll start with you as you're first on my screen.
I really think that the key for getting buy-in is to focus on the results. The results not just for improved outcomes, because isn't that why we're providing care, treatment, and service in the first place, but also in helping the individual being served to understand their own response to this, which increases their satisfaction with the therapy being received.
You want me to go next, Simon?
Sure.
Yeah, I think as a former clinician, just what Melinda said, getting that feedback, that immediate feedback, knowing that there is progress being made. If there's not, what do we need to circle back with, and really doing that patient-centered approach to a joint ownership of the progress that's being made. So, yeah, I hear the administrative burden a lot, especially when it comes to value-based arrangements. And I've had providers say we won't do it because it's too administratively burdensome. But I think there are ways now with technology, with AI, to capture a lot of the data that needs to be captured to promote measurement-based care. So
I would say it doesn't have to increase the documentation burden at all. So in England, we now use our mobile phones, and patients get a reminder of their next appointment as a text message. That's really good because it means you get much better compliance with attending appointments. But then they click on that link and it takes them straight in to the data system, and they just press a few buttons to fill in the questionnaires on their phone. So there is zero documentation requirement for the clinicians, and it goes direct into a modestly priced IT system, and the clinician can pull it up on their computer and see the graphs of progress and discuss it with the patient. And the service can then, get aggregate data of it. So it really doesn't need to be a burden. But the other thing is that I think it improves your relationship with your patients, because patients are really want to get better. And when they see that you're looking at how they're improving, it really improves the relationship. I mean, if we think about, say, treatment of hypertension, someone's got hypertension and you need to get their blood pressure down. Just think what our patients would think if the doctor said, well, I'm going to try out a few drugs to get your blood pressure down, but I don't want to trouble you by measuring your blood pressure or discussing it with you. We'll just keep it going. We wouldn't, most of our patients would not be very happy with us, but that's sort of the way we've been treating people in mental health up to now. And, when we bring them into parity of esteem with physical health, they really appreciate it.
Great. And so I'll move to the next question on the list here. And I think there's a lot of overlap with this one, so maybe we'll work through it a little quicker. And I'll ask to say like anything we'd add on top of what we just talked about. But how do providers overcome barriers of resourcing and funding to implement utilizing MBC and tracking outcomes without manual work, when resourcing, and I'll say and funding, are often big constraints for many? And so this seems like it's how can providers feel supported in this? I know we've just talked about using systems to be able to do this. And I think that's a big part of how you can overcome the resourcing, is avoiding the manual effort on clinicians. It doesn't necessarily cover the funding part of that question. And so maybe I, sort of put this to Sandra and Melinda in terms of any suggestions on overcoming the funding component of it. Otherwise, I have a couple thoughts on my end as well.
Well, I think from the payer's perspective, that there is incentive for a payer to have partnership with their providers. A lot of times in the States, it's written into contracts that there have to be value-based contracts. There has to be improvement. The states have performance improvement projects that the managed care organizations have to do. So I think it does benefit the provider and the payer to work together to work out that funding mechanism. It sometimes doesn't take a whole lot, like Dr. Clark mentioned, technology or an app that can easily be implemented within, and the payer provide that support. So I think there are ways to work together to get that financial support ready.
And I very much agree with what Sandra said, as well as if doing this gives you a better standing with your payers and better reimbursement, that goes a long way to offsetting the costs.
I think I'd add the one piece from the Greenspace perspective is when, we're implemented in such a broad range of settings, and many settings that are community-based, nonprofit, limited margins. And there might not be an opportunity in the moment to go to a payer and have their implementation funded. That maybe is a future opportunity for them once they have the data to enter that conversation. And so I think in our practical experience, like we're seeing the cost of being able to implement a high quality measurement-based care instance, like not overly burdensome, like something that is accessible to even small nonprofit organizations. But maybe more importantly, when we look at ROI, so return on investment, there are other elements of ROI that will come out of measurement-based care for that organization that we are often tracking against and seeing a 3 or 4 or 5 times ROI in the short term on things as simple as client engagement with care, which reduces last minute no-shows and cancellations, which can be a huge, I think, underappreciated cost to providers in the community sector. And so there's a big conversation I think we can have around like ROI versus cost to be able to bring systems in place and invest in the practice. But I think we are seeing it as pretty attainable these days from all the data that's being captured on it.
Yeah, and Simon, I want to add on to that, that there probably are opportunities within the state agencies to approach state agencies around how measurement-based care can help them with some of this, especially in the Medicaid space, and working with CMS, and also with access to care. I mean, if you've got folks that need services and there's a backlog, and you can kind of manage that through, triaging people who are making progress, maybe setting aside those that are not. I think there's a lot of value for the state agencies to look at measurement-based care across a system. So,
particularly giving the results of Norway and other countries.
yeah, absolutely. Yeah.
This next question here, we'll see how many more we have time for, but this next one is for Dr. Clark. You had mentioned that you did not change anything in the therapies provided over the years. I think this is referring to the improvement over time graph, but you improved things through restructuring and implementation of measurements. What restructuring was involved in this beyond implementing the surveys? When we talk about like what drove, I think the restructuring that drove the improvements in outcomes over the years.
So there are several things. So the first one is, although the therapies were the same, the dose did change. So we found there was a sort of general dose response effect. Those services that gave a slightly higher dose did get better outcomes. So we pushed the system to slightly increase the dose. It's not massive. The optimal value seems to be about 10 sessions, but quite a few services were below that. So that was key. We also found that those services that were very good at identifying the primary problem that you're going to treat at the start in their initial assessment. Is it post-traumatic stress? Is it obsessive compulsive disorder? Is it social anxiety? Is it chronic depression? They got considerably better outcomes. So we really pushed the system to do good assessments and get that right first time, so people get to the right treatment first time. And we also found that those services that had higher what we call DNA or do not attend rates, where people don't turn up for the appointment but don't tell you they're not coming, did less well overall. And so we instituted a sort of SMS reminder system to reduce DNA rates. And we found that when we did that in those services, their outcomes improved. So there's a whole series of practical things like that, which seem to make a big difference. The way we structured the supervision of the therapists also helps quite a lot. We also found that in general, the outcomes were not quite so good if the service was located in a very socially deprived area of the country. And you might think, well, that just shows that psychotherapy doesn't help if you are in a really difficult life circumstance. But of course, it could also be that you are deprived of a really good service in that area as well. And you can statistically control for that by controlling for these other quality variables, if you like, that we talked about. And when you do that, you really remove the effect of social deprivation. So just to give a slightly cutesy example, we have two areas in the country next door to each other, which are very different in social deprivation. Our new King Charles, the weekend, is at Windsor in his castle. That is not a socially deprived area of the country. But right next to it is one of the most socially deprived areas of the country called Slough. They're both served by a single, very high quality talking therapist service, and they both get above average outcomes. Slough does slightly better. It has a lot of special initiatives. And so if King Charles felt overstressed by his duties as our monarch, we would suggest he gets the chauffeur to drive him a bit further down the road to Slough to join the talking therapy service.
Love that.
Great story.
Good. Maybe as one wrap up final question to everybody before we jump out, and it's the sort of the next question on the I'll ask everybody to give a sentence or two. What recommendations might you have for senior leaders on supporting and driving an implementation within their system or organization, as a sort of final thought to leave everybody with? Melinda, maybe I'll pass it over to you to start, and we'll go Melinda, Sandra, Dr. Clark.
I really just think, again, it's focus on the benefits here and on the value for everybody concerned.
Right.
I think, and I saw the comment about engage your stakeholders and really engage your clientele, engage your membership, and let them give the feedback. We have found that so valuable at CareSource is to listen to the people who live the experience.
I think those are really good points. I would also say, don't feel that you have to win everyone to the cause at the same time. Really focus on encouraging people who will run with the idea, and then their colleagues will see the benefit of it and they will move along too. So don't be overwhelmed by the idea that there's some opposition in your organizations. You will always find some people who run with it, and that's enough to get the system rolling, and then people see the benefit.
That's great. I think we're going to end it there. And so a huge thank you to each of our panelists for joining us today. I mean, for me, it was a real honor to be able to host the session. I appreciate all the excitement that I'd say our community had for the session leading up, and obviously the attendance today was really amazing. So thank you, everybody, and we hope you have an amazing rest of your day.